Good afternoon, everyone, and a very warm welcome to this special session in our talk show series hosted by Aliança Millions Missing. Today, we're addressing a subject that is both complex and very important to our community: off-label treatments and therapeutic approaches for myalgic encephalomyelitis, chronic fatigue syndrome, and long COVID. It's a real honor to introduce our two distinguished guests. Dr. Susan Levine, a US-based physician and researcher, internationally recognized for her decades of clinical experience with ME/CFS patients, and Dr. Daniela Leal, a Portuguese physician in private practice who works directly with ME/CFS and long COVID patients, bringing insight into the possibilities and challenges of. What makes today's conversation unique is that we'll hear two complementary perspectives: the US private system, where patients often have access to experimental options but face high costs, and the Portuguese private setting, where the realities are different but often just as challenging. The format is simple. This will be a conversation between the two doctors, exploring clinical practice, ethical dilemmas, and differences in access. But most importantly, sharing practical strategies that patients can take away to improve their quality of life. At the end, we'll have time for a few questions from patients. With that, I'd like to invite Dr. Levine and Dr. Leal to begin the conversation. So we'll begin by clarifying what we mean by off-label treatments and why they come up so often in the context of ME/CFS and long COVID. I don't know who wants to begin.
Would you like to address that, Dr. Leal? You want to address that one first, Dr.
No, but
Leal?
you can go ahead, Dr. Levine. I'll speak after.
All right. Okay. Well, the concept of off-label simply means that they're not quote-unquote FDA approved. There is no reproducible biomarker for this illness, or people who've had heart attacks, there's some concrete evidence of disease. This illness is so multifaceted and changeable that it's difficult to create clinical trials that can lead to on-label treatments or approved treatments. So that's sort of what's meant by off-label. And so people doctors and other medical professionals base their recommendations on what has worked for them in the past, what seems reasonable based on the presentation of that particular patient. And sometimes that's dependent on the presence of, for instance, I think you mentioned earlier that you yourself have this, Daniela, the POTS. So for instance, a drop in blood pressure and a rise in pulse on standing, and that can be remedied by a volume enhancing agent like fludrocortisone or even normal saline. So that's one way of attacking the treatment of chronic fatigue syndrome, by addressing one of its comorbid disorders. And so, what it is these treatments aren't written in stone. They're based on observation of the individual patient and what has worked in the past, because of the lack of multi-site clinical trials like we see in other diseases.
Leal, would you like to add to that, or?
Yes, I agree with Dr. Levine, and this is such a complicated pathophysiology and interplay of different systems that it's hard to have such a linear thought process as you have with other conditions like hypertension and diabetes. So things get complicated, and it's harder to study, to develop drugs for these conditions. And I think that's why we haven't seen as much new drugs coming out. And then physicians need to get creative and rely on their past experiences and what seems to make sense, and use and sometimes refurbish drugs used for other conditions as off-label treatments.
Exactly, the repurposing, is very important. Otherwise, if we'd have to wait for entirely new drugs, that would involve considerably more funding and would add considerably more years to the wait that these patients would have to face, which we've already faced for quite a long time. And I guess what I'd add to that is maybe you can both share your thoughts on that just a little bit in terms of the phenotyping of these conditions and the subcategories is not yet entirely clear. We don't have broad consensus. We don't have the final answers on the phenotyping for these patients. And so it's like what Dr. Levine was saying, you have to look at a patient and sort of try to understand the constellation of comorbidities that might be present, correct? Am I understanding it? So it's rather individualized, this off-label treatment strategy. Am I correct?
Yeah. Right. Well, I mean, I think the first thing you ensure is that the patient meets the clinical criteria, which I'm sure Dr. Leal is familiar with, which includes the presence of post-exertional malaise, the cognitive abnormalities or dysautonomia, and the unrefreshing sleep. So that's basic. And then after that, we try to determine whether mast cell activation, for instance, is present, because that gives me some treatment options if the patient has that. POTS, other dysautonomias like gastroparesis, small fiber neuropathy. And now there are some newer ones that I think are been a bit under the radar, like jugular venous stenosis and other structural abnormalities that may be present, and that came to the fore with long COVID. So I think it's important to identify, to cast a wide as net as possible on the first meeting with the patient, to try to plan a strategy for which specialist to recommend to the patient that they see, and then develop a treatment plan.
Moving on to access. How does access to off-label care look like in your settings? So the US private practice and Portuguese private practice. And what can you say, if anything, about the barriers that patients face in the public systems?
I can start. So I only do private practice here in Lisbon, and I'm not plugged in the public system anymore. So what I know from it is just what I hear from patients indirectly. I don't think it's a Portuguese thing, but there's a lack of awareness of general physicians about this condition. So a lot of patients see the door closed, let's say, and they have to find solutions elsewhere. In terms of outpatient access to off-label therapies, I would say the situation is not bad in Portugal. Even if the drug is not approved by Infarmed, which is the Portuguese FDA, let's say, there's a way of importing if it is approved anywhere else in Europe. There's a way of justifying that the patient needs to take that drug, and we're able to import through certain pharmacies. So that hasn't been an issue with quite a few medications. Other treatments that require inpatient administration, like let's say IVIG, I would assume, since I have no affiliation to any public hospital, I would assume that would require a physician that's also working in a public hospital that then can plug in that patient and proceed with therapies. So that's my understanding. I don't see price, bearing some exceptions, I don't see price as being too restrictive here to try certain medications in Portugal. It's more a question of finding a doctor who can navigate these pathways.
Absolutely. Dr. Levine?
Okay. Well, here in the US, I would say there are some barriers to getting costs covered and the opposite, and actually less and good access to the treatments if you can pay for them. So antivirals such as valcyclovir or amantadine, which target herpes viruses, which are thought to be active in people with ME, are easily obtainable, but some of them are not covered by insurance because, again, they're considered off-label and they haven't been shown in clinical trials to be efficacious. So anecdotally, that they match to the treatments for some of the comorbidities like the fluorocortisone for POTS, pyridostigmine, which improves preload and increases blood flow to different parts, different tissues, and in so doing helps with fatigue. Some of the sleeping meds, by enhancing the quality of sleep, will also improve general energy levels. Low dose naltrexone, which I'm sure you've heard about, usually that's not covered, but it's not going to break the bank to get that. And IVGG, as Dr. Leal referred to, we get the patient to get that at home sometimes. And that can be a little challenging to get it approved, however. And yeah. And then some of the newer treatments that maybe we'll be discussing later, like the microdosing of semaglutides and some other treatments like that, vagus nerve stimulation. Those are not too difficult to get through compounding pharmacies or even through ordering them on the internet.
Right. It just occurred to me as you were speaking that when we speak of, for example, challenges in the public systems in access to off-label treatments, the problem might begin with the lack of appropriate diagnosis. So, and in that sense, that question might not even be a question because the patient might end up having to go to private practice to get an appropriate and adequate diagnosis. So in terms of accessing the appropriate treatments, the diagnosis need to be there in the first place, which is an issue that a lot of us face in the first place on the path to try and access the treatments that we might need. To conclude this portion, Dr. Leal already indirectly answered, but I want to ask it again to make it crystal clear, which is when you think there's a specific medication that could benefit a patient, but it's not available in your country or has not been approved by FDA, are there ways of trying to access it? And I have concrete examples. Those would be, for example, guanfacine in Portugal and Sulodexide in the US. Are there ways that you have to try to access them regardless?
A short. Yeah, I'll just give you a short version. I don't think lack of access is a big hurdle here. But, I think more trying to determine the dosing schedule, the amount of drug to be used that's therapeutic, and the duration of therapy is challenging. And in other words, I think there's like a long enough list of medications to try on different patients that are more or less readily available for people. But it's a matter of choosing the right ones and knowing the right doses and how long to keep them on it.
Definitely. All right, so Dr. Leal?
Yeah, like I was telling you earlier, it is possible to get some medications here in the US, in Portugal, that the Infarmed doesn't have approved, but they're approved in other countries like Spain or France. It has happened with some of my patients. So that hasn't been much of an issue, and the cost hasn't been prohibitive either. So yeah, that's my answer.
All right. So I think we can move on to the symptom-targeted approaches. So let's turn to concrete examples now. What do each of you use most often for example, POTS dysautonomia, immune dysfunction, mast cell issues, and so on? So very broad question. I don't know who would like to begin.
I can start, but I must say that I'm not in any way an expert in ME/CFS. I'm here to learn as well from Dr. Levine, who's been doing it for much longer and has a much more targeted practice from what I know. But I'll share what I've been doing, and hopefully it helps. So for POTS, the non-pharmacological measures are very important. So fluid replenishment, salt or electrolytes, compression stockings when tolerated, to avoid the pooling of blood in the legs. Also, lifestyle-wise, eating smaller meals, paying attention to carbohydrate content, because that can increase fluid loss in the gut. And then if you talk about medication, we have the fludrocortisone. So it has a mineralocorticoid activity. It helps the body retain water and salt. Mestinon, like Dr. Levine, or pyridostigmine, like Dr. Levine was mentioning, can increase preload in certain patients. So makes the cardiac output more efficient. There are other drugs that I tend not to use, like midodrine, which helps to increase the blood pressure, but it can increase it too much, so it's a bit difficult to titrate. So I'd say that these are the main things I use for POTS. And also, if to control the heart rate, you can use ivabradine.
Right. Yeah, I would agree with that. I also, in my mind, and even at the beginning, I tell people there's at least two categories of treatments. There's ones where they'll feel some symptomatic relief kind of right away, which I think will give them some optimism. And then there's other treatments which just take longer to work. So, for instance, IV gamma globulin and the antivirals, like I mentioned earlier, the valcyclovir and so forth, could take 6 months or a year to really kick in. And there's really no way of knowing whether they're being helpful, and we just assume, based on our theoretical knowledge of the pathophysiology of the illness, that they are doing something. And then the mast cell stabilizers and the POTS drugs more or less have an immediate effect. Within 24 to 48 hours, you'll know if they are helping, for the most part. So, already mentioned some of the drugs that are commonly used for POTS. For mast cell treatments, we will use cromolyn sodium, famotidine, which is Pepcid, Zyrtec, Allegra. But sometimes I find that we have to use supratherapeutic doses of these drugs. So the drugs that are commonly used for hay fever, the amounts that are commonly used for hay fever won't do it, because we need like sort of systemic level doses. So some people take 3 Allegras a day, for instance, and take maybe, 80 milligrams of famotidine. And then, but we work up slowly. We start at a lower dose and then we titrate upwards.
If I may, where do you usually begin, or rather, what would you say is the minimal therapeutic dosage for MCAS regularly?
Well, I guess you can't really generalize about that. It's sort of patient dependent. But the way you arrive at that is you start at a low dose. So for instance, 20 milligrams of famotidine, and usually twice a day, before breakfast, before dinner, for a week or 2. I would say 2 weeks, let's say, and then I might bump it up to 40 milligrams twice a day after that. And so we base that in part on the patient's symptoms, but also on histamine and tryptase levels in the blood. So those are mast. I don't know how technical you want to get here, but those are mast cell mediators. Yes. Okay. And we measure them in the blood. The other way of looking at it is a 24-hour urine collection for methylhistamine. And that's cumbersome. And a lot of people don't want to carry around a jug of urine for 24 hours and collect it.
That
So,
was
but
personally the way that I got diagnosed with the 24-hour sample collection. So yes, I went
okay,
through that
okay, that's good.
process.
Yeah, right, right. And I have to say that even if you didn't have an elevated level, you might still have, I mean, that doesn't exclude that you don't have mast cell disorder, even in the face of negative testing. Mast cells are very interesting, and they're elusive, and they're in the gut and in the brain. So who's to say that even if your blood test is normal, that you don't have a lot of mast cells active in your gastrointestinal tract or in the part of the brain called the pons? And interestingly, in the bladder as well, because, for instance, interstitial cystitis patients, they've done biopsies on the bladder of those patients, and there's a ton of mast cells in there. So I find it very interesting that it's a kind of a unifier for a lot of the patients, like a thing that everybody seems to have in common to varying degrees. But anyway, to get back to, so the famotidine is well tolerated. Zyrtec can be sedating. That's another, we have it here over the counter. And I use levocetirizine as well, which is Xyzal. I don't know if you guys have it there.
Yeah, we do.
Okay. And then
Cetirizine, yes.
and ketotifen. Do you use ketotifen? The compounded?
Yes.
Yeah. Yeah.
And let me ask you, Dr. Levine, because that's something I don't know, I don't do. So you track the tryptase levels in the blood, and they lower with the mast cell stabilizers?
But I'm not convinced that it necessarily, I haven't come up with a good, tracker for that kind of thing. Yeah, the patients sometimes just feel better, or
Symptoms,
and
yeah.
again, and interesting, yeah. So the mast cell, the other interesting part about it is that it doesn't mean that people are allergic or they're sneezing all the time just because they
Right.
have mast cell activation. It manifests as what we think of as the ME symptoms: brain fog, the fatigue. It can definitely cause unrefreshing sleep. Overly active mast cells can do that. So it aligns very nicely with the ME symptoms. They're not necessarily allergic symptoms that we'll be looking for in a patient with mast cell activation. So that can be a little confusing. But it's a nice thing to have in your pocket to know that you can use the mast cell stabilizers because they're mostly well tolerated, and they're easy to get. They're not too expensive, and they mix well with other medications. And lastly, IV gamma globulin is also a mast cell stabilizer. But that's a kind of an invasive treatment, and for us at least, difficult to get it approved.
If I may, is there any type of medication you go to for flares, particularly difficult flares? For example, first generation H1s, or I know there are even some doctors who during flares go for benzos, etc. Is there anything you go to during, particularly difficult flares of mast cell issues?
I use kind of different types of interventions. I like to use IV saline, for instance, and of course it would depend on, if somebody were hypertensive, I wouldn't use IV saline, but that's an easy way to get them out of a crash. The benzos, caution, because obviously they're addictive, but who are homebound or bedbound. Okay.
Maybe I would like to get your thoughts on a couple more of the comorbidities / components of this whole puzzle. What do you both use for, say, let's go with mitochondrial dysfunction? What are tools you use to support that part of things?
So, from my understanding, that could be mitochondrial, maybe not working well because they didn't get enough oxygen. And then there's a toxic buildup of metabolites that then impairs the normal function of the mitochondria. So it works as like a vicious circle. I tend to use B vitamins, which are cofactors in the Krebs cycle, which is the way the cell produces energy. And then there's some nutrients that can help, like coenzyme Q10, NAC, N-acetylcysteine, L-carnitine. Also, it's in most of those mitochondrial support formulas. Yeah, so that's what I tend to use. Then there's newer things like oxaloacetate, which I believe there's a question further ahead, which I must say I don't have experience in patients with, but I read, and it sounds pretty interesting from a mechanistically standpoint, the way of like speeding up the Krebs cycle and producing more energy. Yes, and then this is part of the complexity of this disease, right? The microvascular problems also impair the mitochondrial function, because then the blood is not getting there as efficiently, the oxygen is not getting extracted. So that needs to be addressed as well.
And
I
what
agree,
are
yeah.
some ways that you support with the endothelial vascular dysfunction?
Well, like you were alluding to, the drug sulodexide is one of the options that can help rebuild the endothelial membrane, and also decreasing the formation of microclots. And then there's some natural substances like pycnogenol and nattokinase. They all have a antioxidant and fibrinolytic activity, so they help to break up small clots that could be damaging the microcirculation.
Dr. Levine, do you have anything to add to that?
Yeah, I agree. Those are very good suggestions with Dr. Leal said. The problem is that the tools, like you can't just test people in the office, at least we can't, for mitochondrial dysfunction, like the commercial labs that we have don't do that. It's in a research setting that one has found out. For instance, Stanford has done a number of trials, and I have with at Cornell. She's looked at mitochondrial post-exertional malaise, and it often manifests as a lowered anaerobic threshold. That means that the person runs out of gas much sooner than the normal adult. And so to go back to what Stanford is now trialing, 2 amino acids, ornithine and aspartate. It's called the LOLA protocol. And these are available through compounding pharmacies. And again, it's the problem of not knowing what the right dose is. I usually start people on kind of a modest 500 milligrams a day dose, and then maybe go up to 1 gram a day of each of these. And those impact mitochondrial function according to their research findings. But again, this is not the kind of test that doctors usually have available. The mitochondrial testing is kind of not easy to access for regular doctors. And oxaloacetate, of course, there have been some studies. I don't know. I don't always find it so effective, but it's possible that we haven't pushed the dose up high enough, because that one is actually quite expensive. And so a lot of my patients haven't really tried it yet at perhaps the therapeutic dose.
Right, and also as far as the endothelial dysfunction side of things, do you have anything?
Yeah, I don't target that one so much, because
Okay.
if you do that, well, I'll tell you, there's a risk of bleeding too. So if you go with some of the fibrinolytic drugs, you can cause the opposite problem of, like, I'm not saying that nattokinase, which is kind of a very low-key kind of anticoagulant, is going to cause bleeding, but you have to be careful. And because the microclotting thing is sort of a concept, more than what we actually see. There's no real blood test to measure that. It's kind of, again, a research level test. So I think in private practice, it's something I don't do so much right now.
Right. That's a recurring theme, unfortunately, that a lot of the testing is so far only happening in studies or clinical trial context, and when you try to translate that into clinical practice, we're faced with all of these uncertainties, right? And there's a lot of trial and error and a lot of going by the subjective experience of the patient, I assume. Yeah. So I would be curious, before we move on, to hear how you address something that I feel sometimes is a little underestimated within the whole picture, which is the microbiome imbalances, GI issues that can come up within this whole story of mast cell activation syndrome and dysautonomia, which can cause gastroparesis, and so on and so forth. And yeah, some of the ways in which you try to address the GI side of things.
In this camp, I have more experience. I have a lot of patients with present with IBS, and I run some dysbiosis tests, like SIBO and microbiota analysis, and it is interesting because I see a lot of patients that also present with mast cell activation symptoms, like migraine type headaches and even like urticaria and GI symptoms as well. And sometimes, many times, from addressing the underlying GI imbalance, those symptoms improve, even if we're not targeting them directly. Yeah, so there's the mechanism there, and it makes sense because you have a lot of your immune system around the gut. You have a lot of mast cells there, and if they're active there, they move around and they release cytokines that then activates the whole system. Yeah, so the way to address the microbiota, you can use antibiotics. For instance, if the patient has SIBO, you can target it with rifaximin plus minus metronidazole and neomycin. These are antibiotics, so you can use herbal products, which are very useful in this setting as well. Antifungals, if there's a fungal problem. And then it's very important to also rebuild the whole ecosystem. And there's some interesting studies showing that in an ME/CFS population, there could be a lack of butyrate-producing bacteria. Now, butyrate is a substance, short-chain fatty acid, produced by good bacteria that then has systemic effects. It's anti-inflammatory, modulates the immune system. So by promoting the growth of these bacteria, theoretically, you could be improving the whole system. And for that, you use probiotics to modulate the ecosystem. So probiotics are bacteria that influence the other bacteria, right? And prebiotics, which is food for the bacteria. Things like galacto-oligosaccharides, fructo-oligosaccharides, resistant starch. They're basically types of fiber that feed bacteria that then exert their metabolic activity and produce substances that can then be absorbed and influence the whole systemic biology.
How about motility? Is there any tool you use to improve motility?
Gut motility.
Yes.
Yeah, there's some prokinetics. Interestingly, one of the drugs that Dr. Levine mentioned, and then I use a lot also in fibromyalgia patients, is LDN, low-dose naltrexone. It's a compounded medication, which also has a prokinetic effect. So it's indirect. It's acting in the immune system and inflammation. It also has a prokinetic effect. There's other drugs like Resolor, prucalopride, which has a prokinetic effect. And then there's natural substances as well. Things like ginger, artichoke, all those help to regulate the motility. Yeah, but I must say, I don't find in the IBS population, SIBO population, that the motility per se, I mean, sometimes it is the driver, but not in the majority of situations, in my opinion.
Okay, okay. Right, so before we move on, just Dr. Levine, if you want to add anything to this microbiome, gut, GI side effects and tools that you use.
I think Dr. Leal summarized it very well. Yeah, I mean, there are too few butyrate producing bacteria. We published something like that recently with Dr. Lipkin. And I do agree that the motility piece doesn't help us that much, which I think is helpful. And I think also some tests see about other types of malabsorption that may be occurring.
Good. So I think we can move on to our next session on ethics and communication. So I'd like to hear a little bit, both of you, how you try to balance hope with safety and respond to patient-suggested treatments.
I'm not sure I understand the question very well.
Okay, so
what do you mean exactly by that?
We're addressing, so essentially how you go about making your risk-benefit assessments, I suppose, is another way of saying how do you try to, in your clinical practice, balance hope with safety? Because as we've discussed so far, a lot of these things are still rather experimental. We're not testing exactly for every single thing. And how do you respond to patient in this patient population? Oftentimes patients come forth with suggested treatments of their own that they're looked into. And yeah, how do you make that assessment of responding to the suggestions and balancing hope with safety?
No, that's actually a good question, because people often will know a lot more than their doctors because they've spent so much time researching on the internet, and they will come with the latest treatment and they want to start it right away. And then, but I find that if I interview and find what to try first, for instance, if they haven't already tried low-dose naltrexone or something that I feel has had enough, has a good track record, I would, like you say, go with the safer drug first, or the one that's been tried and that I'm familiar with. And then if they bring up a drug that's I'm not so familiar with, I really will make an effort to research it to some degree. But it all depends. I mean, if it's a supplement, more or less, that's an easier call. But so there are other drugs, and I don't want to get too deeply into this, but like rapamycin is something that comes to mind, which is a transplant rejection prevention drug. So you don't want to jump into that one right away, because that can have far more serious side effects. But if I've known a patient a long time and they've already been on every other thing and haven't tried that one, and they are assured of getting their blood work done and being monitored closely, then I might consider it, So it really depends on the circumstances. But that is a good question, because patients will often have kind of an agenda because they've been to so many doctors already and they've researched the illness themselves so much. And you do have to be careful. That's right.
Mm-hmm. Dr. Leal?
Yes, I have the same approach. I'm very humble in this condition, and I learn from every appointment with these patients, because they indeed research a lot. And in our last appointment, I learned about rapamycin. I didn't know it was being used in ME/CFS. I tend to be open to suggestions as long as I don't see any reason to be concerned, and always prefer to start with the basic and then add on that.
Right. Okay, I think that more or less covers it. We'll move on to practical recommendations. So if you had to give 2 or 3 low-risk practical strategies that consistently help your patients, what would they be?
I can start. In pretty much every patient, and in this condition as well, I like to start with the basics. Diet is important. An anti-inflammatory diet, plenty of vegetables, which have polyphenols and bioflavonoids that then talk to the immune system in ways that we may not even understand fully. So that's important. Also preventing glucose imbalance, so the insulin resistance, which can be a compounding factor. Sleep must be a priority, as difficult as it is sometimes, but I like to harp on that. Sleep hygiene and medication if needed, supplements, and also meditation practice, so stress management. I find that to be, I mean, it's completely harmless, and this is a condition that has such a weight on patients that their whole mind and spirits can get affected. So it's important to build some sort of resilient practice that can help. So those would be my 3 suggestions. And I must say, this is in addition to pacing, right? But I guess to your community, that's not anything new, right? But
Right.
the need to pace and to recognize the first signs of alarm and stop, yeah, it's key.
I suppose that would be first and foremost.
Right.
It seems now so obvious to at least some of us that we sometimes forget to even mention it. But of course, recognizing one's own energy envelope, PEM threshold, and starting to manage from that and trying to stay within those that envelope is, of course, first and foremost, essentially.
Right.
Yeah, absolutely. Yes, Dr. Levine, if you also have like 2 or 3 practical strategies.
I would second what said. I think it's important to on the other side of the coin is to rest and pace oneself, but I find that it's also helpful for the patient to have maybe 2 tasks sufficient, because stopped working or they've stopped doing, the main activity in their life as a result of the illness, and therefore they've lost a lot of their identity. And I think if they can substitute that with 1 or 2 other things, support groups also are helpful, and but I think also having 1 or 2 activities. And one of the things that I'm developing, as you may know, is a very, very simple yoga practice, and that might include meditation and breathing techniques as well, to reduce the sympathetic overdrive that is present here and that influences immune dysfunction and autonomic problems and so forth. So, I think that's important. Low dose naltrexone and sleep, and possibly a probiotic that I like, is something that I usually recommend when I first meet somebody.
Okay, great. All right, and so with that, we will finally get into our patient questions section. First one would be your thoughts on microdosing GLP-1 antagonists for MCAS management, and namely, is it too early for something like that? And have you ever used it in this patient population?
I have no experience, so I'm eager to learn from Dr. Levine here.
Okay. So this is also a new phenomenon for our practice. The GLP-1 inhibitors are obviously being promoted for weight loss and to help with glucose and lipid control. That was their primary intention. However, people have found that as little as 1/100th of a dose of those medications can also reduce inflammatory cytokines in people, not only ME, but other autoimmune diseases like rheumatoid arthritis, and possibly even help in certain cardiovascular states. They also improve endothelial function, and of course, they regulate insulin, which plays a role in these diseases as well. So what we've experimented with in certain select individuals, depending on their blood sugar and hemoglobin A1C analysis, is using something like 0.01 milligrams of Zepbound, which is a semaglutide that we use here by Eli Lilly. And again, the dosing hasn't been out properly, but we usually dose that at 3 times a week, 0.01 milligram 3 times a week to start with. And instead of getting it, the patient ordering it, the pre-drawn up cartridge, which is what's used in weight loss, the patient gets a multi-dose vial and then gets instructions on how to use it. Now, we've been doing it now for a few months. Some people feel like they have a benefit. I think it's going to be one of those things like low-dose naltrexone where less is more. So I don't intend too much to go up on that dose. I think the lower doses are better and more efficacious for what we're looking to achieve, which would be an anti-inflammatory effect. But I think it's a ripe area for further research and study. It's, again, one of those things, it's hard to know whether the patient is responding or not. You know, we just sort of picked 3 times a week out of a hat. It may not be necessarily the right frequency. And there are also GLP-1 inhibitors available from compounding facilities here in the States that are oral. And because some people just don't want to do the injections. So we've resorted to using microdoses of oral semaglutides that are compounded. So that's an option. So, I mean, it's still early, but I think it's a very promising area. As you recall, you know, in long COVID here, and I don't know if you saw, Dr. Leal, if they used like metformin or atorvastatin, those were some of the protocols that were being tried here in COVID. You know, actually at the onset of COVID, people were using like metformin and Paxlovid in people with acute viral infections. So I think it has a place here, but we just haven't figured out what exactly.
Right.
Yes.
The next one would be, what's your opinion on the effectiveness of supplements as mast cell stabilizers? As examples, we'd have quercetin, luteolin, P, etc. And do you use them in your clinical practice?
I use quercetin sometimes. Luteolin, not so much out of preference. I believe the bioavailability is a bit worse. It's not well absorbed. PEA I haven't used, but I read recently about it. Yeah, my preference is the H1 and H2 direct blockers and mast cell stabilizers like cromolyn. But sometimes, in addition, I use quercetin. And if people don't want to use pharmaceuticals also with good results. It's a matter of dosage. You can go up to 1,000 milligrams twice a day, but it's not as potent as H1 or H2 blocker.
Monoclonal antibodies, do we know enough to use them in clinical practice, and under which circumstances would you recommend them?
So in this regard, I'm limited as a outpatient practice solely. I wouldn't have access to them even if I wanted to prescribe them. From my understanding from the literature, there were some promising data with rituximab, which is an anti-CD20. So basically what it does, it's like it targets the cells that produce antibodies, autoantibodies, right? And the goal here would be to decrease the antibody load because in a subset of patients that plays a significant role. So rituximab had some promising results, but then there was a larger trial which didn't hold, didn't seem to help. But there may be a subset of patients, and maybe just a question, how can we identify them? Because this antibody testing is not routinely used. There may be a subset of patients where knocking these B cells that produce antibodies has a positive result. And then there are other monoclonal antibodies that target other arms of the immune system, which with a similar outcome to decrease the production of immunoglobulins that are being studied. Some with promising results. But I don't think so, from my understanding and from reviewing the literature, that they're being used outside of trials, clinical trials. Maybe in the near future, but not yet. And then, so I think the use is limited to clinical trials. And here in Portugal, even if I want it, I don't have access to it. And then a bit in the same line, but a different mechanism, I would say, is immunoadsorption, which is basically clearing immunoglobulins from the system. It's done, again, I have no access to it. I don't even know where it's done here, if it is done. But it seems really interesting because then you're just basically cleaning, taking a bunch of immunoglobulins, antibodies from the circulation, and this seems to have positive outcomes. The theory would be that you would then stopping certain loops, immune loops that are established in these patients, which is a bit the way that intravenous gamma globulin works, right? Which is, in that way, you're giving a bunch of antibodies that then neutralize the antibodies that are already in circulation. So these avenues, I would say they have a similar mechanism, a bit different, but I think that that probably in the future we'll have really valuable ways of interfering with immunity here.
Just one quick follow-up would be, I guess, especially in the immunoadsorption, we would want to make sure perhaps that viral persistence and or reactivation aren't happening, right? Because that could then mean a problem if we're removed, right? Or am I misunderstanding?
I mean, it's totally logic what you're saying. I just don't know how you can make sure of that, you know, because we don't have those labs and those biomarkers. But I believe that hasn't been a condition in the studies that are ongoing. But Dr. Levine, please share from your experience.
I missed that part because I was disconnected. But I infer that you were talking about the biologics and some of those agents. Yeah, here in the U.S., you know, maybe there've been very small clinical trials, but they haven't. And even Dr. Fluge in Scandinavia, they gave up on the Rituxan, and then I think they tried cyclophosphamide to treat this. the idea is also to deplete the B cells which harbor Epstein-Barr virus. I mean, it sounded like a pretty interesting theory, but you know, I'm just not sure that we're ready for that yet, or whether, you know, after an initial response, we can expect like a durable response, you know, in any case, because I think that it's very, I think there'll always be a reservoir of some kind of viral component, either in the gut or in the brain, that perpetuates the immune dysfunction in this illness. And unless we can find a way to completely eradicate that, I think it's going to be very difficult to overcome the inflammatory, the sort of hyperinflammation that the body's in patients with this. So I don't know.
Do you have a reinfection management plan for these patients?
Mm-hmm. Yes, that's very important. So it's more of a prophylaxis, but vaccination is important in this subset of patients. You want to decrease the viral overload as much as possible in the viral exposure. Careful with exposure, obviously. And then once the person contracts the virus, right? And this is also something I learned from your community. Metformin seems to be helpful in decreasing the exacerbation of symptoms post COVID in this case. And then, even though we don't have clear data on the shortening of symptoms or preventing exacerbation, but I like to use nutrients that make sense from an immune supporting standpoint, like vitamin C, zinc, resveratrol. So I use those nutrients to support the immune system. And Paxlovid, I don't have access here. It's used only in patients, so I can prescribe.
Yes, Dr. Levine, we're talking about reinfection management plan, and if you have one for this patient population.
Reinfection with COVID, you mean? Yeah. Okay. So usually what I've done, and whether this is right or wrong, I don't know, but I certainly haven't had anything bad happen to anybody by doing this, is even if the patient is not very sick, if they get a new COVID infection, but they have ME and, you know, they're pretty weak to begin with, I usually will get them on Paxlovid right away, which is not so hard to get. It was hard to get at the beginning of the epidemic here because now it's not that hard to get here. And then I do 5 days of Paxlovid, indication that, again, improving the sort of metabolic disruption that's occurred, possibly as a result of the acute viral infection, is going to help prevent, you know, worsening of the patient's state. That, by the way, is what I feel that IVIG is doing in a lot of patients. Not so much that it's helping the patient, right, improve that much, but it's preventing progression, or could be even worse than they already are. So that's also difficult to assess, because how would you know that? But there's some indication that it sort of halts the progressive inflammation. And just to answer your other question, I haven't had any, we don't have a facility here in New York for immunoabsorption. So we haven't had, and I suspect that it's, again, sort of a challenge to get it approved here.
I know it's done quite a bit in Germany, at the Charité in particular, but as far as other countries, yeah, I'm also not entirely sure. Yeah. But yeah, that's a very interesting point to IVIG and the reinfection management plan, obviously, because our ultimate goal here is at least a prevention of a baseline lowering, which is one of our biggest fears. We're always watching out for that and trying to.
Yeah.
Okay,
Yes.
so we're coming close to the end. I have two questions left. This is a little broad, but so here goes. What's the place for at-home interventions, medical care, and telemedicine for severe patients, severe anemia patients that sometimes can't even leave the house for all the necessary testing? And what would need to change so that these patients don't lose access to healthcare and fall out of the system?
Well, I can answer that quickly. Here in the US, I mean, if they're very bad, we might not even know about their existence because they have never even been well enough to be carried out to see a doctor even. So I think there's a lot of these people behind, I hate to say it, sounds kind of sad, closed doors that we just don't know about. And, here and there you hear about it, but they're there because there have been some films about it, for instance. But I think it's well, here we're facing a potential shutdown of telemedicine, at least that's covered by insurance. As of September 30th, Congress has to decide whether they're going to continue. And I think, Millions Missing. I think there's several advocacy groups that are pushing Congress to extend that telemedicine initiative, which obviously is very helpful anyway. But I have people who can't even get on the phone, who want to do like an e-consult, which is not great, but sometimes it's reasonably efficient. They'll write down 3 detailed questions and we go back and forth that way. And when they feel well enough, they can answer one question, or they can have the home caretaker answer it. It's even getting on the phone, especially, and I always feel bad about this, if I'm half an hour late in calling them, they've already exhausted their energy envelope that they saved up for to just be on the phone with me, and so there's all those issues that you don't even think about. But I think if it works well, telemedicine could be an option. And we also have, and it sounds like you might have it there, home blood drawing services. I can order from one of the commercial labs that somebody be drawn at home. But some of the sort of fancier tests where the tube has to be centrifuged and frozen right away often cannot be done that way. So there's a limitation on the types of testing that can be done at home. But I mean, I think, certainly hope we can preserve what little telemedicine we have now, because I think it's definitely going to be useful. And, way in the beginning of my practice, I did house calls. You're not going to believe it. I actually, when I started out, I was young and I would actually go to people's houses, but that's obviously not too practical. Nobody does that. But like I said, I think there's a lot of people out there with ME that we just are undercounted and we just don't know about because, they're too sick to even seek care to begin with.
Absolutely. The quick follow-up to that would be the role of the caretaker, right? Sometimes there's no way around a patient needing a caretaker for some level of advocating and logistical organizing, right?
That's difficult. Often these patients, sorry, I have a thing for this. Wish I had more knowledge or experience about it. But so a lot of the patients are in their 30s or 40s. So that means a lot of their caretakers, it could be the husband or the spouse, but oftentimes it's the parent who's also quite, who's frail themselves. Let's say they're late 60s, 70. And I find that these older ladies and men are coming in with their 30-something-year-old kids, and they're already themselves in poor health. And that's a big problem. And I have patients who tell me, my mom does better than I do. She can walk farther than I can. Stuff like that I hear a lot. The other issue is here, if you're middle class and have okay insurance, it doesn't pay for a home health aide. It's the people who have the lower income that actually, strangely, which I guess is a good thing, get home health, to get paid for visiting nurse and so forth, to qualify for home health aid. Everything's a little bit difficult in the system. And then the other thing is getting to the office. I know we're talking about telemed, but we have this accessoride, like a bus that takes people to doctors if they can't use the public transportation system. And just to qualify for that is like really, they make it very difficult. Everything is kind of an obstacle to overcome, unfortunately.
Yes, many obstacles. Dr. Leal, any additional thoughts on that issue?
Well, here in Portugal, I think we're a bit behind in terms of like home assistance and the types of services we can offer. For instance, what Dr. Levine was mentioning, the importance of IV fluids in a flare. I don't have any system developed for that, but that's something that maybe I need to look in and be more aggressive. But usually those types of services here are a bit more are a bit harder to get. And about insurance, I'm not familiar with how the insurances pay for this type of services, but I would anticipate it to be a bit difficult. So we need more awareness in this field, and like Dr. Levine was saying, I mean, there's a lot of people that they can't even they can't even get up and shower, let alone take care of all these logistics.
Yeah, exactly. We have come to our last question. This will be a question, if Dr. Levine doesn't mind, a question asked in Portuguese, exclusively for the Portuguese context. So, Dr. Daniela Leal, como é que vê a evolução na provisão de tratamentos para a AEM e Covid longo em Portugal?
Infelizmente, eu não estou tão familiarizado assim como gostaria com a área que eu presumo que seja quem abrange mais esta categoria, seja a reumatologia, e qual o processo atual de desenvolvimento de redes e disponibilização de drogas e tratamentos para esta condição em Portugal. Portanto, eu não estou familiarizado com o envolvimento nacional nesse sentido. Talvez a Joan saiba mais que eu aqui.
Joan, would you like to say anything, or shall we just?
No, I think that, I mean, there was an excellent question, which was, Dr. Levine, it was, how does Dr. Leal see the evolution in the provision of treatments for ME and long COVID in Portugal? And I think the truth is that we're still at a level where we're trying to educate people that the illness exists. It's even a step before that. So I think,
Yes.
and
yes, but you're very passionate. I see it. Yeah, I think you'll get.
Yeah, we've been very fortunate that we have vanguard doctors like Dr. Leal, Dr. Wink, the doctors really that have started to participate in talk shows and have taken upon themselves to develop seminars in the specialty meetings of the pulmonology associations and hopefully soon of the internal medicine. And we're still really trying to get the word out. And here is where the advocacy that you provide and your willingness, to talk about a subject that is poorly understood, that is in some cases even challenged by many physicians, is so important to us. It's important to us because you can convince other peers on a peer-to-peer basis that the illness exists, that there are clinicians and researchers that are very eminent, that have extraordinary experience, that even though we don't have a lot of answers, there are treatments that we can try, and there are certainly some treatments that we cannot, we should not try. And then ultimately, I think Daniela's work is so important, which is, and really what we try and do as a collective, which is to bring about high-level conversations through the conferences that we're organizing, involving the Portuguese Medical Association, involving some of the specialty organizations, to really try and put this illness on the map, so to speak.
Absolutely. Because we don't, as far as I'm aware, correct me if I'm wrong, we don't even have anything like an estimate of a prevalence of ME/CFS in this country or anything of the sort. Yeah, so.
And we're going to try, we're trying to work towards guidelines. Our collective is translating the Bateman-Horn guidelines and the ICANN guidelines. And I think once we have those, the idea is to convene an expert working group so that we have the Portuguese consensus on how to consolidate some of the recommendations there on diagnostic, how to diagnose, and the basic treatments that we can try, and then perhaps the promising treatments as well. So and we look forward to involving you in all of this. I know we're really presumptuous, but whenever we find a friend, we just don't let them go. In fact, we become stalkers. So
you guys are very good. No, it's very professionally put together, and you all seem so knowledgeable about it. Oh, good.
Yeah, Daniela is just.
Thank you very much for having me.
So with that, I suppose I'm going to say my final remarks to close out the session. So as we come to the end of this session, I want to warmly thank both Dr. Susan Levine and Dr. Daniela Leal for their generosity in sharing their clinical insights and reflections. This has been a rich dialogue that highlighted differences between the US and Portugal, but also many common points, the need for innovation, safety, open dialogue between doctors and patients, and above all, informed hope. I'd like to ask each of you for a final thought to leave with our patients today. Dr. Levine, Dr. Leal, what would be your closing message?
Closing message is that there's already been a fair amount of progress. There's over 5,000 research papers published on me and long COVID in the literature, and becoming familiar and are becoming truly interested in this mystery illness, and are sort of sad, but with the advent of impetus to learn more about the illness and to study it. What I was going to hope for is that it gets introduced, I hope, at least into the Portuguese medical school training system, because I think you need to get it from the bottom up, and the students need to be, trained even at a very younger age, that it's a true illness and it should be in the lexicon of their textbooks and as part of like all their other illnesses, so that they can identify it, and that, certain others, those doctors that work, and I guess the state-run system will also be able to identify it, and of course the private doctors can as well, but so that there's more equality in terms of distribution of medical care, and that all the doctors learn about it equally, I guess. Yeah.
Absolutely. So important. Dr. Leal?
Yes, I think there's hope. I think long COVID has been a catalyst. So, as we say in Portuguese, há males que vêm por bem. And to stay together as a community, keep advocating, keep trusting your community, keep asking uncomfortable questions to doctors, and the word will spread out. And like Dr. Levine was saying, the teaching is key here, and if we can educate our younger doctors to be aware of this condition and to look for it, then everything will be different in the future.
Yes, thank you so much. So thank you both so much, and thank you as well to everyone who participated. Your presence and questions are what make these sessions meaningful. We invite you to follow our upcoming initiatives at Aliança Millions Missing, including, of course, the second International Conference on Clinical and Scientific Advances in ME/CFS and Long COVID, which will take place on November 12th and 13th in Porto, Portugal. Thank you so much, everyone. We look forward to seeing everyone again soon.